Hello, I'm Richard Ayler, Associate Professor of Medicine with the Division of Infectious Diseases and International Medicine at the University of South Florida. Today, I'm going to be speaking about a more recently recognized phenomenon regarding methicillin-resistant Staphylococcus aureus. My interest in this topic stemmed from an article that myself and several of my colleagues published in Lancet Infectious Diseases in July of 2009. The article related to some of the infectious syndromes associated with cat and dog exposure. A segment of this article included information on MRSA associated with pets. And I think that this topic, although we've recognized the potential association between MRSA and companion animals for decades, the recognition and understanding that pets in the household could harbor MRSA is a relatively more recent understanding. So I'm going to talk today a little bit more about the idea and the relatively new one that MRSA could not just be a humanosis, in other words, that MRSA could not just be transmitted between human patients, but also of the idea of MRSA as a zoonosis, not just in the companion animal population, but in other areas as well. Before we get started, let's talk about the basics of resistance where it relates to Staphylococcus aureus. Now, we all know that the altered penicillin binding protein that confers penicillin resistance to Staphylococcus aureus is known as penicillin binding protein 2A, or PBP2A. And PBP2A is carried on the MECA gene. The MECA gene resides on what is known as a staphylococcal chromosomal cassette, or SCC. This is the mobile genetic element that can transmit resistance between bacteria, particularly staphylococcal bacteria. SCC MEC type 4, although there are several types now, actually at least 6 types, SCC MEC type 4 is the smallest cassette which happens to carry the MECA gene common to community-acquired MRSA strains. Now, Pantin-Valentine leukocidin is a fusion protein commonly found on community-acquired Staphylococcus aureus strains that is a marker for pathogenicity. And the most common community-acquired MRSA strain here in the U.S. is what is known as USA 300, or sequence type 8. Now, we can see in this diagram how the MECA gene incorporates into the staphylococcal genome via the SCC MEC mobile genetic element. SCC MEC again encodes for PBP2A, which is the altered penicillin binding protein that can continue to synthesize cell wall peptidoglycan even when the normal PBP receptors are saturated. When we talk about the epidemiology of MRSA, nowadays we like to talk about reservoirs. So in MRSA we have the healthcare-associated MRSA reservoir. This is the traditional reservoir of what is known as a USA 100 or potentially USA 200 methicillin-resistant Staphylococcus aureus, which began as a phenomenon in hospitals, involved MRSA strains that were susceptible to numerous antibiotics, and was typically associated with surgical procedures and prolonged time in a healthcare setting. The community-acquired reservoir of MRSA, more recently described, involves MRSA strains, unique MRSA strains, originating in the community, which originally caused community-associated infections, typically skin and soft tissue, which could cause outbreaks outside of the hospital. They were strains adapted to thrive outside of the healthcare setting. including USA 300 MRSA, which I've spoken about just a few moments ago. The community-acquired MRSA reservoir is now becoming more universally prevalent, not just in the outpatient setting, but also in the hospital. MRSA is certainly a factor in fomites, that is, hospital, medical equipment, surfaces, and a variety of different environmental substances or surfaces that could harbor strains, not just in the hospital but in the community. Community-based fomites, for example, might be the artificial turf in a stadium where two sports teams who transfer community-acquired strains of MRSA could come in contact with. Gym equipment, environmental surfaces in an institution such as a prison, and so forth. Also, clothing or towels or other personal grooming equipment can be potential reservoirs of MRSA, specifically the community-acquired strains. And we see this in hospitals too, where sometimes medical equipment can harbor healthcare-associated MRSA. So a potential fourth reservoir of both healthcare and community-acquired MRSA may be animals. And this can include companion animals, so-called companion animals such as dogs and cats, but also livestock, pigs, horses, poultry, and other more livestock-associated animals not associated with traditional reservoirs of MRSA. And there's growing recognition that these potential reservoirs may have an impact on society in several different ways. So let's think about the phenomenon of MRSA in animals in two different respects then. Companion animals, dogs and cats, but other pets in the household have been implicated as potentially harboring MRSA, such as reptiles potentially, and even pet birds as well. With livestock, again, we see poultry, veal calves, horses, and pigs as being potential reservoirs of unique strains of MRSA. And a more recently recognized phenomenon is MRSA documented in animal food products. And although there have been some limited research in this capacity, I think it's fair to say that the effects of MRSA in our food supply are perhaps not as well studied. So when you look at MRSA in animals, a couple of things are clear. Companion animals harbor distinct strains of MRSA that are different than those carried by livestock. The companion animal strains tend to be the ones that are typically carried in human populations that are passed on to companion animals from their owners or from other humans as a humanosis. These strains may then have the potential to be transferred back from the companion animal to others in the household, or to other humans such as veterinarians or other animal handlers, which may acquire the MRSA strain subsequently from the companion animal. On the other hand, MRSA strains in livestock tend to originate in the livestock and then can be passed on to human attendants or other farm staff as a zoonosis. And the effects of this potentially can be significant and serious. MRSA colonization and or infection has been documented in many different animals, not just dogs and cats, but sheep, poultry, horses, rabbits, psittacine birds, turtles, bats, and even small mammals such as guinea pigs and chinchillas. As I've said before, the chief strains of MRSA associated with pets are the ones typically associated with humans. So early on we saw USA 100 or sequence type 5 MRSA being acquired by pets, usually through owners or other animal handlers who may have had some experience with the healthcare setting and then passed this hospital-associated strain of MRSA on to their pets. But with the emergence in the U.S. of community-acquired MRSA strains, such as USA 300 or ST8 as it's also known, it's the USA 300 strain in the U.S. that is becoming more associated with acquisition in companion animals. Now, among livestock, particularly in Europe, we've seen a distinct MRSA strain associated with these animals, and this is ST398. In fact, in pig stocks, there's been a strong association with ST398 in several studies, and ST398 colonization has been documented in the Netherlands, France, and other countries. Reports up to 2005 documented MRSA in pets in many different countries, including those in South America, Europe, Asia, Northern Europe, Africa, as well as in North America. In the last 4 years, we've seen additional countries such as Australia, Canada, Germany, and New Zealand, for instance, documenting cases of MRSA in pets. This is a much more widely recognized phenomenon in recent years. My personal interest in this topic originated when I saw this article about a dog named Bella who was one of the first, perhaps the first, pets in the United Kingdom to have developed a surgically or post-operative associated MRSA infection following orthopedic surgery, ultimately and unfortunately leading in the animal's death. Bella's owner, Jill Moss, was so overcome by the loss of her beloved pet that she decided to do something very positive about it. And she established a charity called the Bella Moss Foundation to promote information awareness of the phenomenon of MRSA in companion animals. And over the last couple of years, I've become more involved with the Bella Moss Foundation and the good work that it does to promote awareness of this subject. And I think that charities like the Bella Moss Foundation can go a long way towards promoting awareness, which is unfortunately and sadly not as widespread as it should be in the huge numbers of people who own cats and dogs and other companion animals. I'm going to step back for a second and talk about some milestones of MRSA associated with companion animals. And our recognition of MRSA in cats and dogs, for instance, actually dates back to the dawn of the MRSA era. As long ago as 1959, Mann and colleagues isolated Staph aureus from the nares of almost a quarter of tested dogs. And this was the first recognized evidence of Staph aureus colonization in pets. 2 years later, Live and Nichols hypothesized that antibiotic-resistant Staphylococcus species could colonize vet hospitals. Now this is really at the dawn of the MRSA era, and yet there was recognition that veterinary hospitals could be colonized by staphylococcal species. The first report of hospital MRSA occurring in an outbreak from a companion animal dates back about 20 years to 1988, when a United Kingdom ward cat was linked to a recurrent outbreak of MRSA in a geriatric unit. And elimination of the outbreak occurred only when individuals were decolonized. And I believe that the animal had to be decolonized as well. In 2004, a long time after this documented MRSA outbreak in 1988, Van Dukeren and colleagues documented transmission of MRSA colonization from a healthcare worker to a dog. And since then, there have been several other studies documenting the same. Owen's report in 2004 also was a description of the onset of septic arthritis in Bella Moss, the United Kingdom dog for which the Bella Moss Foundation charity is named. And again, this was thought to be perhaps the first well-documented post-operative fatal case of MRSA septic arthritis in a UK pet. In 2006, Vitali and colleagues documented the isolation of community-acquired strains of MRSA, specifically USA 300, from a domestic cat. And this was perhaps the first isolation of community-acquired MRSA from a pet that was documented in the literature. And in 2008, Moodley and colleagues documented that MRSA carriage was actually higher among veterinary practitioners than the general population, with an odds ratio of 3.9 versus 0.7. There have been numerous other studies in the literature, far more numerous than I could document in this brief talk. What are risk factors for MRSA in companion animals? Well, typically this is household residents with a colonized pet or human. So colonized pets may spread MRSA to other pets or even to other humans. And primarily, as I've said before, pets acquire MRSA originally from their human owners or human handlers. Pre-existing skin disease in a companion animal can be a risk factor for acquisition of MRSA. Previous hospitalization or surgery as well, and the extensive or limited use of antimicrobials in a companion animal are all risk factors. Most MRSA in companion animals is predominantly skin and soft tissue disease, but as we've seen with animals such as Bella Moss, postoperative infections, specifically orthopedic infections, can occur. And as more medical devices are utilized in pets, especially related to hospitalization in veterinary hospitals, device-related infections may also occur. What are some risk factors for MRSA acquisition in cats and dogs? I've adapted this from a talk by David Lloyd. Contact with a human carrier is associated with an odds ratio of 7 in acquisition with cats and dogs. Surgical implants have an actual higher risk than even human contact. Admission to a vet clinic for 2 or more days may greatly increase risk factors for MRSA acquisition, as the animal becomes even more susceptible to contact with a colonized vet personnel, with a colonized veterinarian or other vet personnel, or contact to fomites or medical equipment that may have been contaminated through use in other colonized animals. The highest risk factor for MRSA acquisition, however, is at least 3 different courses of antimicrobial drugs. And as more broad-spectrum antibiotics are used in companion animals, in particular those that happen also to be used in humans, more and more animals meet this criteria for acquisition of MRSA. And as I've said before, MRSA colonization and MRSA acquisition is not just a problem in companion animals. In recent years, there's been a greater recognition of strains, specific strains of MRSA being recognized in livestock and in animal products such as meat. This article is from London's Daily Mail from 2007. Documented cases of MRSA in livestock animals have occurred in horses, where they have caused a wide range of clinical syndromes, from skin and soft tissue disease to bacteremia to osteomyelitis to device-related infections to mastitis and even pneumonia. Mastitis outbreaks in cattle, which may even spread to handlers, have also been documented. And pigs have been documented as suffering from an exudative dermatitis. In fact, we've seen that MRSA from pig and cattle reservoirs have been responsible for up to 20% of human cases of MRSA in the Netherlands, a country whose background MRSA rate is astonishingly low otherwise, secondary to very aggressive infection control strategies for MRSA in the human population. It's quite remarkable to notice how much MRSA in humans occurs from these livestock reservoirs, and this has been well documented. In fact, there have been several case reports of MRSA transmission between livestock and owners or attendants. For instance, there was a case report of MRSA transmitted between Hungarian cows with mastitis and an agricultural worker, published in EID in 2007. And there was a second case report of MRSA mastitis in a Dutch pig farmer's wife whose husband and daughter developed persistent colonization. Studies published in the last 4 years have documented that about 23% of Dutch pig farmers are nasally colonized with MRSA. Again, a much higher rate than in the background population in the Netherlands, where MRSA colonization rates in the general population are extremely low and much lower than in many other Western countries, such as Great Britain and the U.S. And the specific strain that's associated with this livestock MRSA is ST398. ST398 was first identified a little over 10 years ago, and the hypothesis is that a native pig MSSA strain acquired MEK-A from other staphylococcal colonized pigs, or perhaps from staphylococcal strains carried on human pig handlers. This has now become widely distributed across Europe and has even been described in North America and Canada and in Asia and Singapore. Human infections have been characterized, including endocarditis, ventilator-associated pneumonia, and wound infections as a result of contact with these colonized pets. And the majority of ST398 MRSA strains are tetracycline resistant, perhaps reflecting the fact that tetracycline based products are widely prevalent in the animal food supply, added as a growth promoter. And when MRSA occurs both in livestock and in companion animals, veterinary personnel can also become subsequently colonized. And this can produce some remarkable statistics. Studies have shown that the nasal carriage rate in human medical personnel is about 0.3%, whereas the nasal carriage rate in one study in American vets was many dozens of fold higher, about 6.5% in fact, in American vets. And the odds ratio was much higher in a large animal practice than in a small animal practice, again reflecting the higher likelihood of transmission of livestock MRSA strains to veterinarians as opposed to companion or small animals, which seem less likely to transmit that to veterinarians. The carriage rate among veterinary personnel working with pigs is even higher, estimated at about 12.5%. Again, compare this to the nasal carriage rate among human medical personnel, which is only 0.3%. Again, this is some several hundredfold higher than what is seen in, I should say this is about 41 times higher, 40 times higher than the nasal carriage rate seen in medical personnel. So what is it that causes veterinary personnel to have such a high acquisition of MRSA? Is it something about the specific strains that colonize large animals? Or is it something about large animal veterinary practices that cause veterinary personnel to be colonized with MRSA at a much higher rate? This area is due for some significantly more aggressive research in as far as epidemiology is concerned. Now let's spend a few moments talking about MRSA in meat products. The studies that have looked at MRSA in the food supply are relatively limited. However, a recent epidemiological study in the Netherlands showed that about 39% of slaughterhouse pigs are MRSA positive. That's about 1 in 5, or about 40%. Typically ST398. And a survey of meat in Holland showed that about a third of turkey, about a quarter of chicken, 17% of veal, 1 in 10 samples of pork and beef, and about 6% of lamb were contaminated with MRSA. 84% of these were non-typable MRSA. Now, the authors of this second survey, looking at the data, concluded that they did not feel that foodstuffs played a significant role in human MRSA. Now, that may be true, but in terms of the significant other reservoirs and risk factors to MRSA in humans. But I would conclude that it's not well known whether these foodstuffs play a significant role, and certainly more research needs to be done. I think if you ask the average person, do you know that there's MRSA in your pork or beef or turkey, they would have no idea. So with the lack of recognition, I think there's a lack of good clinical studies looking at whether any transmission can occur. This is I should make it clear, my speculation, but again, I think everyone agrees that more research needs to be done in this area. Now, what are some issues in companion animals for managing MRSA? As an advisor to the Bella Foundation, the foundation sends me many referrals from pet owners in the U.S. who have infection control and management issues regarding MRSA in their companion animals. And of course, I should make it clear I'm a human infectious disease doctor and not a veterinarian. And so I typically deal with the human issues within the household and leave the pet decolonization or treatment issues to the family vet. Well, sometimes decolonization of the pet is necessary, but typically this is done in the case of a persistent infection in the household, typically among humans, where the infection has recurred and it's felt that there's a persistent reservoir of MRSA present in the household. So routine decolonization is not advised, but sometimes, in a case-by-case basis, decolonization of the pet or decolonization of the owner and other humans in the household has been necessary in order to eradicate recurrent MRSA outbreaks. Sometimes good infection control is necessary to document where the MRSA reservoir is in the household. Is it in the pet or is it in some other inhabitant of the household or some other factor? If a pet in the household is MRSA positive, is there a risk factor to cohabit pets in the household so that potentially other pets in the household are at risk? And a big issue regarding pets is in situations where a pet owner may need to board a MRSA positive animal. A lot of times they have difficulty in boarding these animals in kennels or veterinary offices or in other establishments where pets are boarded, because if a pet is known to have MRSA, a lot of times there is a resistance with boarding that animal in a facility where other pets are also located. What is the risk for transmission of MRSA in the immunocompromised or sick pet owner or handler? And should the pet be quarantined from that person? This is a big question. And when do you exactly treat active MRSA pet infections, and to what degree? Do you use systemic antimicrobials, topical antimicrobials, and when is it appropriate to do so? These are all questions where there are no clear guidelines. There are a variety of drugs useful for controlling MRSA in animals, and these can include topical antibiotics such as mupirocin, which incidentally is not available for, not recommended for use in many European countries, but where they use fusidic acid. But because fusidic acid is not available in the U.S., mupirocin is often recommended for eradication in pets. And again, this has caused some concern about the potential for further gram-positive resistance among mupirocin in the U.S., where it is used in pets as well as humans. There have been some cases documented where topical vancomycin has been attempted to eradicate MRSA in humans and pets, but this is not widely recommended because of the potential for vancomycin resistance. Chlorhexidine is another agent, and systemic antibiotics widely used in pets include the tetracyclines, the macrolides, occasionally rifampicin, and chloramphenicol as well. What are some issues for management in MRSA in livestock? And these are not well answered in particular, but I bring them up for discussion. Should livestock be decolonized, particularly if they're prone to colonize veterinary personnel or to contaminate food products derived from the livestock? How often does transmission occur to farmers and vets, and how can this be prevented? How often does transmission occur of MRSA strains in the food supply, and what are the effects of this? If 1 in 10 meat samples in the Netherlands, for example, are positive, 1 in 10 beef samples are positive for MRSA, could this be potentially transmitted or contaminate other beef and be a factor in human health? What are the rates of MRSA resistance in the livestock strains, and can these strains acquire other resistance from other MRSA strains, or can they similarly transmit resistance to other susceptible Staph aureus strains? And how does antibiotic susceptibility factor into management issues for MRSA in livestock and in the food supply? In circumstances where MRSA decolonization is necessary, in an outbreak in a household, for example, published cases suggest that close affiliation between vets and human physicians is necessary. Case reports suggest that decolonization of livestock animals has been successful. And in companion animals, transient colonization can be treated with topical scrubs and antiseptics, although it should be noted that companion animals vary in their tolerability and the practicality of decolonization. Decolonizing a dog, for instance, would probably be easier in terms of applying topical antibiotics than a pet cat or a bird, for instance. Now, one of the most widely known and preeminent veterinary organizations for pets, the British Small Animal Veterinary Association, which has taken a lead in commenting on MRSA issues in companion animals, has asserted that decolonization in small animals can be attempted, quote unquote, if the human companion is immunosuppressed or otherwise vulnerable. And typically this is done using chlorhexidine scrubs and almost always fusidic acid if it's available. If not, then mupirocin is recommended. So in the livestock and food supply segment of this discussion, we often deal with the issue of decolonization of livestock, again, transmission to livestock handlers, transmission in the food supply, MRSA resistance, and the issue of antibiotic susceptibility. Now, this was from a Frontline documentary on some of the industry changes and modern changes that have occurred in the meat industry. And this section can be accessed on the Frontline website. But I thought it was interesting, and they dealt with a section on the use of antibiotics in the livestock industry, not just for therapeutic purposes, but this was specifically in the sub-therapeutic use of antibiotics, typically as growth promoters and to promote the size of livestock with regard to their output of meat in a livestock agricultural type of concern. And in this special, the authors of the documentary asserted that farmers add antibiotics to livestock feed because animals increase their weight up to 3% more than they otherwise would. And a 3% margin in the livestock industry can be significant enough to make a big difference on a financial scale. And each year there's an astounding 15 to 17 million pounds of antibiotics used subtherapeutically in the U.S. Now, concerns about the growing level of drug-resistant bacteria has led to the banning of subtherapeutic use of antibiotics in many European countries, in the European Union, but also in Canada. But in the United States, such use is still legal. And these include many classes of antibiotics which are also used in humans. And it's felt that it's the subtherapeutic use of antibiotics in the livestock industry which has the greatest potential for inducing further antibiotic resistance in human medicine. The World Health Organization has recommended that prescriptions be required for all antibiotics used to treat sick food animals and has urged efforts to terminate or rapidly phase out antimicrobials for growth promotion if they are used for human treatment. Perhaps the most egregious use of subtherapeutic antibiotics is in the use of fluoroquinolones. Now, many of you know that fluoroquinolones are perhaps our strongest and most potent oral antibiotics used in human medicine. But yet the use of ciprofloxacin and a cousin drug of ciprofloxacin known as Baytril or enrofloxacin is common in the agricultural industry. And there have been calls for the banning of fluoroquinolones in companion animal veterinary practice and in livestock animal practice. But there has been some resistance from the veterinary industry about a total ban on these drugs and a push for more of a self-imposed restriction or control of these agents for use in small animal and large animal veterinary practice. But there has been a movement in the U.S. To control the use of subtherapeutic antibiotics in farm animals. And the state perhaps taking the lead in this initiative is in California, where there was a bill that recently has been considered to ban the use of antibiotics in farm animals. If this bill passes, it will be seen, I think, as a landmark in controlling the use of antibiotics in the nation's food supply, with the hope of perhaps preventing further antibiotic resistance. California has adopted many initiatives that have ultimately become more widespread in the U.S., and so there may be a move in subsequent years, if this bill is approved, to spread this practice to other states. Amazingly, most human antibiotic classes, which contain antibiotics used in humans, also happen to be used in animals. And this can include the penicillins and the cephalosporins, sulfa drugs, the macrolides, the tetracyclines, but also the streptogramins, and even the aminoglycosides and the fluoroquinolones. And there is significant concern that the use of antibiotics used in humans in animals will render some of the more potent human antibiotics less useful, or in some cases even obsolete. So we've taken quite a pathway here to discussing this topic, from the idea of MRSA as a companion animal pathogen to the idea that it could be in livestock and therefore move to humans through the handlers of livestock on farms, but also potentially from the food supply, to the idea of antibiotic issues in both companion and large animals, and how antibiotic resistance to MRSA and other resistant pathogens can occur as a result of the lack of good antibiotic stewardship in the veterinary profession. It's a lot of ground to cover. So let's just summarize for a moment our recognition of the progression of MRSA from just being a humanosis to being a zoonosis. So we know that a previously unknown reservoir for MRSA may be in companion animals and food-related animals. And in pets, MRSA strains can be acquired from human owners and may cause colonization or infection and potentially spread to others. We know that in livestock, specific MRSA strains such as ST398 are common and can spread to human handlers, or may be found in animal products derived from livestock, such as meat. MRSA contamination of meat products has been well characterized in the food supply, and its effects are poorly characterized, and further research needs to be done. And lastly, factors promoting the increase in MRSA and other antibiotic-resistant bacteria may include the use of human antibiotics in small and large animals, the use of subtherapeutic doses of common antibiotics in the livestock population as growth promoters, and also the lack of good antibiotic stewardship when it comes to therapeutic doses of antibiotics in both small and large animals. Well, for more information regarding this topic, I would refer you to our Lancet ID article appearing in the July 2009 Lancet ID, as well as the Bella Moss Foundation website, which is www.thebellamossfoundation.com. Thank you all very much, and we'll see you again in another podcast on idpodcast.net.